Hello, everyone. My name is Sarthak Parikh. I'm the orthopedic surgery and trauma research fellow at St. Francis Health System. And today I'm going to talk to you about a case report on a pediatric subscapular abscess. So I want you guys to imagine that you're a parent and you have a 2-year-old girl. And you're playing with the child, everything's fine. You're in the living room, she's playing on the couch, and she falls on her left shoulder. She cries, but she gets up, and then everything's fine. Everything's normal, right? So you move on with your day, you move on, and then a week later, there's some pain and swelling. Okay, so now you're a little bit concerned. So you go to the ED. They say, "Oh no, it's a wing scapula. It's not anything traumatic. Everything's fine. You can follow up outpatient." But the pain gets worse. You feel more uncomfortable. So you go into an urgent care and they say the same thing. Okay, so now you're like, something's off. I'm not sure what's going on, but we'll just follow up outpatient because that's what the doctor said. 1 week after that, you start to see some swelling, some redness over here, and some chills and fevers from the patient. Now you're concerned because that's a sign of infection. And there's, as a mom, you're seeing this huge swelling, you're worried. You don't know what that is. You don't know what it could be. So you go to the ED again and you get the doctors over there order an MRI. Over here, you can see the MRI report as well as the x-ray. And you'll see there's a massive swelling on the inside of the scapula. It's hazy, there's some septations, the patient has fevers, chills, it's almost on the whole underside of the scapula, and it also kind of moves posteriorly on top of the scapula as well. So now you're concerned about an abscess. And you're not sure because you've never seen this before, because there's only 5 cases in the literature that actually have shown this in the pediatric population. So you're not sure exactly what to do. So you consult orthopedics and pediatric orthopedics. And obviously, you have to wash them out. You need an irrigation and debridement to remove the abscess. So you book the patient for an irrigation and debridement. But as a surgeon, you kind of have to ask yourself, okay, what kind of approach do I want to do? Because this is a large abscess. Are we opening up the whole back of a pediatric patient? Probably not a smart move. You got to wait for the wound to heal. There's complications associated with that as well. So the pediatric surgeons here chose to do it through arthroscopy, which was a beneficial treatment approach for this patient, because you don't have the long incisions, you're able to see everything really well, and you're able to use your tools to kind of scrape out as much as you can. So that's exactly what we elected to do. So after the first irrigation and debridement, we elected to do a second irrigation and debridement. We put the patient on clindamycin and vancomycin, and after about 4 weeks, the patient felt fine. She resolved completely. She was on antibiotics for a total of 6 weeks, and overall, she recovered well, and there aren't any complications from the procedure, which is great. Now, the key takeaways for this presentation is that, one, it's the only subscapular abscess treated with arthroscopy. All the other ones were open. There were about 5 cases in the literature that talked about the management of subscapular abscesses in the pediatric population. All of them were open. The causative agents were MRSA, as well as SSA. And there's also a few case reports in older individuals with Haemophilus influenza. But the one thing that we saw was that all the patients that had MRSA required multiple surgical debridements, whereas everyone who had MSSA only required one surgical debridement. The other thing was that that all the patients recovered. So there wasn't any instances in septicemia. That could also be because everyone was treated appropriately. But you imagine if you had a kid who was 2 years old and you did not have the resources to go to the emergency room, then what would happen? The patient would probably end up having sepsis and not be able to survive if it wasn't managed appropriately. So that's all I have for this presentation. Any questions? Sure. I'm not sure. I don't think so. I can't recall appropriately. I can't provide you with the best answer. Any other questions? So the only patients who required multiple irrigations and debridements were the ones that had MRSA. All the other ones was only once. So I don't know if there's a correlation to that, but that's just what the literature said as to how it was treated. You might only need to do it once, you might need to do it twice or 3 times, but that's just what the literature said. There isn't like any conclusive evidence as to how to appropriately manage it with, how many debridements should we actually do. All right. Thank you. Yeah.